Hi, everyone. Welcome to Quality. This is Arjun Venkatesh, your host, where we're exploring quality in emergency care. Today is the next in our podcast series focused on substance use disorders as part of the Emergency Quality Network. And I'm really excited to have as our special guest, Dr. Shantanu Agrawal, who's Chief Health Officer at Elevance Health, also an emergency physician. And we're going to dig into a lot of things today related to the healthcare system broadly, how payment works in the healthcare system, and what that means for emergency physicians or medical directors out there trying to improve SUD care in their EDs. Shantanu, welcome.
Thank you very much. Thanks for having me on, Arjun. It's great to see you again. I'm a big fan, and so it's I really appreciate the opportunity to be here.
And fun fact, full disclosure, Shantanu went to high school with my wife back in the day in Toledo, Ohio.
Lived in the same neighborhood down the street from each other.
Yes. So I'm going to kick off with probably the first question a lot of people are thinking about, Shantanu, which is, what is Elevance Health? You're an emergency physician. I've never seen them advertising for ER docs in the back of an ASAP now.
That's right. So Elevance Health, we are a large health benefits and services company. Your listeners may know the brand Anthem, Amerigroup, some of our other brands. That is all under the Elevance Health umbrella. So overall, we provide insurance for over 45 million Americans across the country, all different kinds of insurance, Medicare Advantage, Medicaid, the ACA individual marketplace, employer-sponsored insurance, and then we've got a health services company as well called Carol.
That's very helpful. And so help me think about that, because I know one of the biggest sort of businesses within sort of that Elevance umbrella is being a payer for healthcare services. And in that role, I'm sure you guys have a lens to basically everything and anything happening in healthcare. And so how did you sort of come about to focus and prioritize substance use disorders to say that, we could support anything, but we're going to actually support work around alcohol use disorder, opioid use disorder? How did that decision go?
Yeah. So, first I'll say it is really critically important for us. I mean, at an enterprise level, we really talk a lot and take really seriously whole health. So we have a whole health strategy that underpins our corporate strategy. I mean, it's our answer to how we're working to drive healthcare value and affordability. My job here, I get to focus on whole health. I mean, that is addressing health equity, addressing social needs, quality, the outcomes of care that we're able to achieve. And you can imagine as an ER doc, you get access to a lot of the issues in our society that then I get to turn around and really focus on here. So it's actually quite an amazing honor to be here in this role. Substance use disorder. So, we decided a couple of years ago that SUD would become a major focus area for our foundation. We've got a private foundation. We focus on 3 different areas after we really took a step back and decided, well, where can we drive impact and what would really matter to the health of the nation? We decided to focus on food as medicine programs to really address chronic disease burden in society, maternal health, particularly because of the yawning inequity in maternal health outcomes in this country, and then substance use disorder. And what drove SUD, and obviously I should say, you're a grant recipient of the foundation. I'm really, really proud of the work that you're doing. To be able to kind of re-engage the ER community from this standpoint is incredible. But why SUD, to your question, is, look, about 40 million people, right, 12 and older in the United States at some point in their lives, at some point in the past year experienced an SUD issue. Whether they were formally diagnosed or not, they could have, and we see this in the ER all the time, they could have abused a prescription drug, an illicit drug. And, when that level of kind of disease burden exists in our society, of course, it affects their families very directly, and it affects the country as a whole. I mean, SUD is, of course, part of this huge national conversation. So health impact, financial impact, and we decided that would be logical for us to focus on. We're in a number of states and communities around the country. So what we do through our foundation is really make sure we're getting foundation dollars into the communities to really drive community level impact. We made a commitment 2 years ago to spending $30 million over a 3-year period, specifically in substance use disorder, access to treatment and treatment itself. And so far, I think we're about 2/3 of the way through and have more grant making opportunities coming up.
That's awesome. We'll come back to the substance use disorder part of the thread in a second. But one of the things you pointed out that I think is really interesting is what you described as food as medicine. And there's a tremendous now, I think, awareness and attention around social determinants of health. I think food and housing and income security are probably the three that I think are just, they almost feels like these massive problems, right? They extend across race, across geography, across almost any strata in the country. And in emergency medicine, it's common to feel like you see the patients and you see the ills that result from those gaps in social determinants of health. And more importantly, often in the ED, you feel like, well, what can I do to really change this, right? Like I can deal with the problem the patient has right now today, but I can't change all of that upstream. And I have to think that you also feel like, it's hard for one company or one payer to think that they are going to reverse all of the challenges around social determinants of health. And so how do you approach these social determinants of health in a way that you can have sort of meaningful impact, but also, realistic impact, I guess, at the same time?
Yeah, such a really important question. And I think you capture so well that feeling that you have of being powerless, of not being able to affect the core issue that's really putting that patient in front of you in the ER and maybe even over and over again in the ER. I have to say, moving to this side of healthcare, I mean, one of the big drivers for me was really doing something about addressing health-related social needs. Again, as a company, we have resources to do it. I think we've got scale and reach. And I think this industry really needs to do it because we are accountable for total cost of care, right? So that's, I think, one of the benefits of being on this side of the healthcare ecosystem is because we are responsible for total cost of care, you can think longitudinally about a person in a year and even longer, right? And you think about all of the different businesses we're in, Medicaid, Medicare, ESI, we can literally be with a person through many different stages of their life. And so that puts into place some of the impact and financial pieces that you need in order to really invest in an area like addressing social needs. So I think your question about like which ones are really important. We can and should play a big role. I think delivery systems can play a big role, but our impact can only go so far. We cannot replace the social safety net. We can't replace the public sector, but we can work alongside those elements to really make sure people are assessed for their social needs and get connected to the right resources. So what we are doing both on our for-profit side as well as in the foundation is working to assess people's social needs, right? Really trying to figure out what drives the health outcomes and the healthcare utilization that we're seeing. What you said is exactly right. Food, housing, economic insecurity, those are major drivers that we see in our membership and our data as well. And then we ask, okay, so if we can get that information at scale, and that, by the way, isn't trivial when you think about having millions of members that you're responsible for. But if we can get that information, what kind of resource can we connect them to that is the right resource for them? We do look first at our benefit design, right? So we offer a number of social related benefits across particularly Medicaid and Medicare. There's been this growth in supplemental benefits, they're called in Medicare, that really address social needs. We have value added benefits in Medicaid. And then interestingly, a number of our employer customers are also interested in adding benefits like this to their plans, recognizing that their own employees still have these social needs, even though they're commercially insured and they're employed and all that, but they still have these social needs. So first is benefit design, and then the second is creating connections to community-based organizations, getting people connected to the social safety net, the community kind of safety net that already exists in their communities and can really help to address their needs. The last thing I'll say, because Arjun, I could talk about this all day, and I recognize we're at a time-limited podcast. The last thing I'll say is I'm really passionate about food and the power of food as medicine. And when I say food as medicine, I differentiate nutrition insecurity. So that is eating the right food, that isn't processed food, that isn't unhealthy food, from food insecurity, which is not having enough access to food, right? Not knowing where your next meal may be coming from. These two things clearly overlap and interrelate with each other. But I think what's interesting is food as medicine, as a nutritional insecurity idea, affects so many Americans. You look again at our chronic disease burden, hypertension, diabetes, CHF, CAD. I mean, the preponderance of our society that has these conditions, and often a few of them, is tremendous. And I think fundamentally it comes back to a bunch of quote unquote choices we make, and food is a central one of those choices. I mean, the penetration of just sort of processed food in our diet, food that is not healthy for us, fresh, locally grown. That's too expensive a set of choices for many people to make in our society. And so they head down a path where developing chronic diseases is almost expected. And then the way we handle it, as you know, right, as clinicians, is we start turning to medications. And while I don't think realistically we'll replace medications, I'm not even sure that's the goal. We should think of food interventions and dietary changes as yet another avenue for addressing this chronic disease burden.
I want to connect a couple threads you had there, which is what I often think of as, increasingly talk to health economists around us, this horizon problem. And so, we were talking about how in the world of SUD, as a payer, you're often thinking about how can we best manage the total cost of care? And if we can get people into treatment, we will reduce ED visits, hospitalizations, overdoses, a variety of things that will improve the cost of care. But one of the challenges is, even with something like benefit design, is we do that every year. And the reality is that addiction is a disease that is with somebody for life, and the outcomes are very longitudinal, even when they're acute in that on a year-to-year basis. And so how do you build a horizon, whether it be for people with substance use disorders or people with food insecurities, when you're in this business that sort of operates on an annual basis with each person? We know there's big churn in Medicaid every year, so that they've got sort of lifelong health, right? That we've got lifelong supports for people to get the right care at the right time.
Yeah, it's a really good question. So part of the answer I gave you already, which is, the sort of the diversity of our model and the fact that we again can offer so many different kinds of products that people can choose, means that we can have more longitudinal interaction with a member than many companies. So we talk a lot and take quite seriously about being a lifetime trusted health partner for our members, right? So that changes some of the inherent dynamics around it. If the person is transitioning from Medicaid to Medicare or commercial, whatever the case may be, if we can still kind of be their partner on that journey, it actually opens opportunities that we wouldn't otherwise have. Part of the answer too is actually, when you address social needs, what we have found is that you can have impact in less than a year. I mean, it's not off the table to dramatically change what we see from a total cost of care, from a healthcare utilization standpoint, from a health and quality outcome standpoint, that completely aligns incentives for us. So if you look at the research on this, something like a medically tailored meal intervention, when you think about food as medicine, that can have impact in 3 to 4 months, right? And measurable impact in decreased ED utilization for some kind of out of control chronic condition like diabetes, measurable impact in unnecessary hospitalizations, measurable impact in some of these medication use. So all of those things are the right thing for the member, right? They're healthier. And because it's altered utilization and cost, it's also the right thing for us. So that's exactly the kind of aligned incentive I think we can pursue. We executed a program. So this isn't just sort of external research. We created a program for our own associates. When you think about, we're a large employer, we self-insure. We created a program for associates to basically give them a grocery card that they could buy fresh fruits and vegetables, sort of good, healthy groceries with. And we followed these associates now for 2 years. And I can tell you, within year 1, we started seeing changes to their self-reported behavioral health and their claims, healthcare utilization within that year, to the point where it achieved statistical significance within a year, within a budget cycle, essentially, right? So they reported better mental health. They reported eating better. They reported that their family ate better. And we saw more outpatient use of services, fewer ED visits, fewer hospitalizations. And net, that program is now financially self-sustaining, and we've had it for 2 years in a row. We're going to have an expansion of it next year. So I do think the window on these impacts can be a lot shorter than people imagine or think. But again, you've got to have the right relationship with a member. I mean, it is that total cost of care picture that makes it feasible for us. And the last point, Arjun, is that's also why we have a foundation, The foundation invests in communities long term, right? So it doesn't have to be on a 1 year cycle. We are there. These are communities that we as a company, we're I think an 80-year-old company. We've been in these communities for decades. We will be in these communities. And so when we invest in the foundation, we're investing in community level infrastructure. We're hopefully leaving infrastructure in place that will really be there long term, even beyond our grant window. But that's why I love to see strategic initiatives cut across sort of the for-profit business and the foundation, because they operate differently, they think differently, the incentives are different, and it's just a way of furthering our impact and making the duration of that impact longer.
Here's the thought experiment. Do you think there's ever a future world where I could buy a 10-year insurance plan or a 20-year insurance plan, and it would come, designed with additional support on a lot of these other things, where basically I could sort of make a commitment to say, hey, I'm going to be insured for the next 20 years with you, and you're going to commit back to me for the next 20 years of my health. Do we ever have that in the future?
I can imagine a number of CFOs in my business that would be welcoming of that model. Look, the reality is, on a day-to-day basis, we do, and again, I mean this quite seriously, we have to earn our members' business. Medicaid, you can switch plans. There's lots of subpopulations in Medicare where you can switch plans quite often. We have to make the argument to them on a day-to-day, week-to-week basis that we're the right plan for them, with the right services, the right access to providers, the right benefits. And employers, quite frankly, yes, they tend towards longer duration contracts, but again, that is reassessed quite often, and it's always their business choice to reassess that even more often. So I don't think realistically very long-term contracts like that will become the dominant ones. But I think we've gotten very used to this sort of needing to make the argument on a real-time basis, making sure we are meeting our members' needs, their employers' needs, and essentially earning that business. I do think when I talk to employers about this area, about addressing SUD, addressing food issues, addressing social needs, these are really areas of interest to them. I think more and more employers are seeing the impact of these issues on their business, right? Their employee productivity, the duration that they are able to keep and retain employees. So there is, again, business alignment to things that really matter for them that has really opened the door to some new conversations about, great, well, let's think about health more broadly. Let's think about addressing social needs, think about addressing behavioral needs earlier, and augmenting the great work that our provider networks do for you. Because of course, you and I know this, a doctor can't do all of this. There are other players that must play their role. And I think employers are really welcoming of that message these days.
And doctors, I think, right, increasingly feel like the system is remarkably complicated. Working well within it is really hard. Trying to do the right thing for the patient is really hard. And so, you guys are in each of these different segments: Medicaid, Medicare Advantage, employer sponsored. And when we talk to the sort of physicians, clinicians out there, they sort of often will think of insurance either monolithically across all of these. And when that's just not really the case, right? Everybody has a different plan and a different configuration. But where do you see as sort of the big access blocks that we need to get out of the way in order to make care better? We often hear about prior authorization. We hear about coverage variability. We hear about a lot of these sort of copays and other incentives that make it so that in that micro level, the thing that's more affordable for the patient is less desirable for their either their total cost of care, their care coordination. Where do you see those, now that you're sort of on the payer side, the things that sort of get in the way of the right thing happening?
Yeah, so a complicated question. Let me give you a few answers. First, I do think access points are a problem. So again, if you live in certain rural parts of the country, access to primary care, already problematic; access to specialty care, even more so. And then quite often, as a result, you'll end up in an urgent care or an ER for something that is clearly a primary care need. I think technology can play a really important role there. We saw over the pandemic the incredible role that telehealth can play. It needs to be integrated into sort of an end-to-end clinical model going forward. We should never move away from that. Other digital tools and apps also need to be integrated, right? We work hard to try to make PCP care available on your smartphone for our members. Through telehealth, they can do that with their longitudinal PCP. They can do that in an urgent care setting. I think all of those tools are really important so that members can get access on the timetable that makes sense for them, sort of where they need it, when they need it, right? That's often what we talk about in quality. Now, having said that, I do think all of these things need to be assessed, right? So we shouldn't just come into this thinking, well, it's a digital app, therefore it's going to be great for access, patients are going to love it, and it's going to have wonderful clinical outcomes. None of that is guaranteed. You've got to assess those kinds of outcomes for everything we put in front of a patient, a member, to make sure it truly is meeting their needs. I think a second issue is, these social needs we're learning are real barriers to care. So why is it that we see such a health equity challenge in this country? Well, there are frankly many, many drivers of that, as you know, but one of them is community level resources are not equitably distributed. So I often say internally, externally, that all of us reflects in our individual health, the health of our community. If your community is unhealthy, if it does not have access to good, fresh food, grocery stores, resources, then you can work as hard as you want, but there's an intrinsic limit on the health that you can achieve at an individual level, and vice versa, right? If the community is well resourced, you are better off. So that resource can be good food, it can be safe neighborhoods, safe streets. It could also be, again, primary and specialty care. So partly, I think our job as a healthcare ecosystem is to think at that community level, and remove barriers that keep people from accessing the traditional care system that we need them to access, and really make sure that they can improve their health. They're sort of on a pathway to health.
The telehealth and disparity thing is really interesting because on one hand, I see exactly what you say, which is that, the growth of what we have seen in some of both just digital health tools, but also just telemedicine services has been, rapidly created access, particularly in the space of substance use disorders. Yeah. So there are now many places around the country where there may be a patient with an ED overdose in whom buprenorphine gets initiated. And historically, there's a very limited brick and mortar community of primary care docs and addiction specialists to go to. But if they can transition either in a bridge level or even maybe for continuity level to a telemedicine provider to manage that buprenorphine treatment or the treatment for alcohol use disorder, all of a sudden you have widely expanded access. And I see that as this wonderful promise. On the other hand, we know there's this massive digital divide that for all those who suffer from various challenges with every different social determinant of health, those are the exact same individuals who are less likely to have broadband access, smartphone bandwidth, you name it, or even have these tools made accessible to them or be in insurance products that pay for that and cover that. And so how do we use sort of the big machines of payment policy and those big levers to actually let telemedicine close the gap rather than widen these disparities?
Yeah, right. There's no single solution to all of this. On the telehealth side, like we need to make sure that those interactions, like we need to encourage, promote, reimburse the interactions that really benefit the member, the patient, right? So we want to make sure there's no abuse of telemedicine, that these are not just add-ons, that they're having real clinical care is being done. I think of licensure as a basic issue, right? We suspended a lot of those rules during the pandemic, and it opened the door to access. I think we've got to thoughtfully decide which of those rules go back in place so that, again, the member patient can get the care they need when they need it from the right provider. In terms of broadband access, I mean, again, you're right. The good news here is there are government resources, right? Like our government is investing in broadband access. We can help members take advantage of that. So we are looking at more programs to, make sure they get access to the resources for broadband, so that they can use all of these, great tools that we're trying to put in place. I think more knitting between, the private sector and the public. I mean, what's interesting is there are so many resources made available through community programs, through public programs, broadband access, even SNAP. I mean, that SNAP has been around for a long time, and yet our Medicaid members don't get on SNAP. And there's a multitude of reasons for why that is. I think, as we think about my companies, you think about your company, hospital, like there's just more that we can do, I think, to better connect people to the resources our country already makes available that can, quite frankly, change their lives dramatically, and then allow them downstream to take even more advantage of these other apps and modalities and everything else that we're putting in place. So that's something that we are trying to really think about. Like, how do we get people connected to these resources? How do we promote it? How do we help them? How do we make it easier? Because frankly, a lot of people don't get access to these public benefits because it's so hard and there's so much abrasion involved, and it's just challenging for them to do while they're also dealing with sort of the day-to-day challenges of their lives. So that is an area where I think both of our companies can play.
Yeah.
Arjun, the astute listener will notice you said prior auth, and I never said it back.
Yes.
I don't want them to feel like I sidelined or escaped the question, because I do.
We
think
should never miss a chance to talk about prior authorization.
Look, I used to work at CMS, and I led program integrity a few years ago before I went to the National Quality Forum, and then before I came here. And the central challenge that is on my mind is we know that there's inappropriate healthcare utilization. You know this, I know this. You're a health policy guy. You've read all the papers and more than what I've read, right? 40% of healthcare utilization may not be value adding for the patient. 40% may be inappropriate, wasteful care. And there's a lot of different drivers of that. We need systematic, scaled approaches to reducing inappropriate care, low value care. Organizations like ours, delivery systems like yours, are trying lots of different tacks to get us to a higher value, affordable, sustainable healthcare system. Value-based contracting is obviously something we work on together. And yes, I think prior authorization plays a really important role there. I say that not from simply a private payer standpoint. I did this for the federal government as well, representing taxpayers. Without it, I think we don't have a tool that we need in our tool belt to affect inappropriate care, wasteful, low value care. Now, that doesn't mean we don't have opportunity to do better at it, to be more efficient at it, to digitize it. We are working on all of those things. I just think the conversation can't be about not doing it, because it takes away an important tool that we need to have to make sure patients are getting the care they need and not unnecessary care.
Well, I also think the other thing about it is when we talk about prior auth, we're often thinking about it at what I call sort of last stage prior auth, meaning that a series of decisions and other discussions, already things happen until you hit that sort of last moment where it is this, horrible back and forth of paperwork and fax machines. And so I guess part of the question is there a way we rethink healthcare delivery where we apply digital tools, where we sort of partner in the use of AI and a variety of other things where, in an ideal world, you're right, it could be part of the tool belt, but you should almost never need to use it.
I'm with you. I think if we could put a bunch of these solutions together, it'll be better for us, better for the physician, better for the member. I think, again, using digital, we use digital. Like, what we have found is if the delivery system will give us real-time access to their EHR data, we can actually do prior authorization for them, and upstream, right? We can reduce the time it takes to get a yes on prior authorization from weeks to literally days. We're trying to get it to hours. And the other thing we can do is we can actually look in the medical record for information that might be missing from the request and just fill in the blanks ourselves. So I think, to your point, right, digital tools like that can make it more seamless, make it easier, make it less of a barrier. We can probably do it, through other digital approaches that are member facing as well. I think value-based contracts help, bundled payments help. Like, these are all, again, like a multitude of tools to make it less abrasive and ultimately get to where I think we're all aligned in going, right, which is higher value, more sustainable care.
So the value-based contracting one is interesting. I want you to, play double agent for a bit. You're an emergency physician who's inside the payer organization. And you've sort of seen, like you said, this on the federal side and in the private sector. I think one of the things that we hear when we have a lot of community enrollees in the network that are trying to start up programs to treat people, particularly with opioid use disorder. And they're trying to partner with their hospitals to figure out what the ROI on this looks like. And most of them function in fee-for-service medicine. And the reality is that it's disproportionately going to be publicly insured visits in which there's an opportunity to, initiate BUB, do an induction, whatever it might be in the ED setting. And it tends to be a pretty time and person intensive activity. You're at the bedside a lot, right? You're putting a lot of work in, but it's not the kind of work that gets measured in RVUs. There's no central line, there's no intubation, there's no critical care time. And so what you often sort of hear is that, that it's sort of, there's not a good sort of business case, right? That we don't have a payments, our fee for service payment system doesn't help us do what we want to do with SUD care and the ED. What would a better future look like? Like, is there sort of an emergency care episode around this? Are we sort of, is there the likelihood of a bundle for SUD care, things like that? Like, how would we sort of fit into something that would allow us to flip this model a little bit?
I think near term, there could be solutions like bundles for SUD care. I think that you can do within the current construct. It's a matter of having a creative conversation with the relevant payers, right, in your community, maybe even employers. Because a lot of these decisions, I think maybe sometimes physicians don't realize, like a lot of these decisions are actually driven by self-pay employers. And so if you can bring them to the table, it just adds another stakeholder that can really move the needle. I think beyond that, it's really about getting creative about the payment model. So if you want to address specific social needs, that's a real conversation to be had. I think we have to alter the way we think about reimbursement, alter the way we send in claims or even what the claims are about. And frankly, who provides the service? I mean, you and I in the ER have been used to seeing patients with social needs, but I fundamentally ask myself, am I, with my training and background, the right person to assess a patient for their social needs? Am I the right person to get them connected to social resources? My training seems kind of discordant with that, right? Like it seems like I've been trained to do other things and not necessarily address this incredibly important area for patients. And so I think in order to get creative about payment models, you have to start asking, well, who's going to do the work and who should get paid for it? And that might widen the aperture. It might make us more creative about different care models. And yes, it can be attached to traditional care settings, perhaps like an ER, but the work can be fundamentally different. I also think you have to carry that through policy, right? So we're clearly hearing from CMS, just like you are, that they want social needs addressed, right? There's a NPRM out there right now, basically making this available in the physician fee schedule. So they want it assessed, they want it addressed, they want the healthcare kind of ecosystem and infrastructure to tap into the community infrastructure. Well, policy's got to back that up, right? So a conversation that we quite often have with the federal government is, yes, we also have a whole health vision. It's also oriented around this incredibly important domain in social, and yet we are not paid to address social issues. Do that, right? Align our incentives. Let us, think of social as really improving health, and then cover it in all the health-related policies that payers already respond to. And I think that kind of thing would change what we do rapidly, and would push downstream to you and other physicians, right? I mean, we would start seeing, in my mind, different quality measures that emphasize social. We would see different payment policies that emphasize social, different CPT codes and different reimbursements, right? Like that is how you upend the system. The policy does matter. And I think we're so oriented around getting to health that we will push those policies forward.
It's a good point, because it's not that, no emergency physician's trying to get rich taking care of substance use disorder. What it is there's no model to sort of build exactly that team you describe. I need a community health worker who's going to help me engage with people, build those relationships out in the community, but maybe it's a social worker coverage in the emergency department, whatever it might be. But the team is bigger than sort of the emergency physician and nurse that you need for the sepsis patient, right?
And the broader again, set of skills. You have all the access to the federal level health policy, right? Like that affects risk adjustment. It affects CPT codes and reimbursement rates, and affects, your and my favorite thing, quality measurement, right? That's how you build incentives into the system. I think that's that's the level of change that we have to see in order to get something like social truly embedded.
No, I agree. We got to hardwire it into the system.
Yeah.
Right. Versus what we do right now is it's a tack on or add on whenever we deal with everything.
Right. And then your case of like the business model, right? You got some person out there is having to bend over backwards to make the business model. Well, if you make these changes, the business model lays itself out.
Yeah.
Right. Like right now, if you get into even a total cost of care value-based contract with a provider, the provider isn't necessarily oriented around these social issues, because they still have a workforce with a particular expertise that they know very, very well. They're used to doing certain things highly effectively, and you can be more effective and more efficient in those things and drive outcomes in the value-based contract. So it is not automatic that it's just get the right arrangement and equity and social will start being addressed. I don't think so, right? You've got to create the right incentive structure. You've got to make the relevant changes, and then you've got to get physicians and others oriented around that change.
That's a great point. Actually, I'm going to stop it there because that was so great. No, I do think you make it's been a wonderful conversation, because I think one of the, we often sort of in the emergency physician community really often have our lens, which is the lens that sort of we feel every day working in the pit. And it's hard to be able to sort of step back from that for a second, think about how that fits into a broader picture, what else is going on, sort of both nationally as well as sort of in these larger institutions that affect the patients, who, will often take care of on their worst day, right, on their most tragic day. But we don't get to often see when sort of these, when they have some of these better outcomes and when some of these needs are addressed. So thank you for joining today. This was a wonderful conversation. I always give everybody a soapbox at the end of the podcast. And so anything that you want to make sure that the emergency physicians out there who listen to Quality hear, this is your chance.
I appreciate it. This has been really a fun discussion, and thanks for the opportunity again. It's actually great to sort of talk to my people. I hope the listener is getting something or has gotten something out of this. I obviously as an ER doc, like I truly respect what ER physicians do. It's hard. It's physically laborious to run around an ER all day. And I think, again, you see so much, and you see people, as you said, in their worst moments, but also quite often with these massive issues that are tied to our society, that are tied to the country, and that the ER doc doesn't feel well equipped to handle. I'd love more conversations. If your listeners have ideas for what I can be doing in my role to kind of further their work and really address these needs, I'm all ears. And I do, Arjun, want to leave with a message of just expressing deep appreciation to our foundation and to that team. They are doing fundamentally important work. They are literally in our communities. You think about the SUD work, like, we have work going on there that is focused on getting kids access to more education about SUD so that we're sort of better preparing them. We've got grants offering more services, more access to care, digital and otherwise. We've got, work that you're, the incredible work that you're doing in the ER. So it's I think important reach. It's an ounce of prevention. It's a lot of different cures, and it's just been amazing working with this foundation. That's one of the favorite parts of my job, and I just want to give them a very appropriate shout out for all that effort.
Of course, we want to thank the Elevance Foundation as well. Without that, I think we would not be having the substance use disorder initiative across the country this year. Particularly, wouldn't have been able to span out to alcohol use disorder, and so it's been wonderful having your support to be able to launch this important effort. And we'd love to have you back. I'll just sort of ask that we sort of formalize that agreement that Elevance will triple all emergency physician reimbursements across the board.
Wait,
and we'll get you right back on to talk about it.
Did I say that?
All right. Thank you.
Appreciate it, Arjun. It's awesome. Thank you.
Thanks.